Today, we're sort of going to be talking about how to take a history appropriately, and this will be mostly focused at sort of a first year level, but we can add in some tips and tricks that we've found along the way. So I think the first thing that people don't realize is that actually from the moment that you enter the patient's room, those first impressions matter, and you need to really make a positive impression. So knock, introduce yourself clearly, and have a smile on your face. Walk in there confidently, looking like you know what you're doing. Don't walk in timidly, looking around, looking for who the examiner and who the patient is. You want to try and focus in immediately. Then the next thing you want to do is, once you've introduced yourself, then you want to try and check what actually is the patient's name and date of birth, and then it's time to actually gain informed consent from that patient. So that patient might not know exactly why they're there, or they might have an idea in their head. Obviously in the OSCEs, they'll be scripted and they'll have their scripted answer. So at this point, you're going to explain what you're planning to do today. So, whether that's taking a history, doing an examination, or anything else, you need to explain that fully. And then you need to actually seek permission. And you could say something along the lines of,
"Hello there, my name is Peter Rafferty and I'm one of the resident doctors here. Would you mind if I get your name and your date of birth? Thanks. So today I'm going to be taking a history from you. That'll just involve me asking some questions about your health. Is that okay with you?"
Yeah, absolutely. So once you've done that, you've got a really good start and a really good basis. I think then the next sort of main point, and especially on the marking schemes, you'll see is, what is their presenting complaint, and hopefully they'll tell you as soon as you have asked those questions. So you say, and why have you come in today? And they will tell you what their presenting complaint is. And I think at this point, it's really important just to let them speak. Actually. Often, in GP and things, there's the sort of golden minute or so. I know that's difficult in OSCEs, but I think just give them as much time to speak as possible. So normally that is sort of 30 seconds up to a minute, and they'll tell you exactly how they're feeling and what they're wanting out of the consultation and what they're worried about.
Just a crucial tip, something I've noticed from marking OSCEs, is some students will accidentally close off their open question. So an open question is, "Tell me what's brought you in today." But some students will accidentally close this off and they'll say something like, "Tell me what's brought you in today. Was it chest pain you were having?" This immediately closes off the question. Simulated patients are always trying to help you and they're always trying to guide you down the right path. But if you don't ask those couple of open questions at the start, you might go down a path that you weren't supposed to go down. So always ask that open question and then allow that silence and allow the patient to speak.
Yeah, and actually I really like the silence because it gives me a few seconds to collect my thoughts, settle my nerves a little bit, and actually allow me to sort of think about what is going to be my next question based off what they're saying. I think the really important things to do is not to forget their name, not to forget their age, not to forget what gender or age they're meant to be, even if they don't look like that in the OSCE, and then also not to forget what they're actually saying at this point. It's easy for your mind to wander. So just listen, sit and listen patiently for the minute. The next thing you're going to do is based off of their, presenting complaint. So for today, we'll take a basic example of something like chest pain. You're then going to use, the Socrates history or the Socrates framework for pain. And Socrates is something that sort of you're taught within first year, but that just stands for site, onset, character, radiation, associated symptoms, timing, exacerbating and then relieving factors, and then severity overall, scored out of 10. And that's something that you can use for any form of pain. And it's certainly something that I use as a basic structure if I'm not quite sure where I'm going to go with the history just yet. And that allows me to explore, a whole number of symptoms.
Absolutely. Socrates is pivotal. You'll use it throughout your career and it's an excellent framework. For other symptoms, we will employ the OPERA framework. So this is for things like if the patient comes in with a cough, you'll use this, and it stands for onset, progression, exacerbating and relieving factors, and associated symptoms. So right from the start, if the presenting complaint is pain, you're going to use Socrates. And if the presenting complaint is really anything else, from a cough, from breathlessness, you then move into using the OPERA framework.
Yeah, absolutely. And that'll be a good way to pick up exactly what the patient is trying to elicit there. I think the next thing we really have to discuss then is ICE. And this is something that all the way up to finals, I think actually becomes more important as you sort of progress through your medical school career. Is something I probably didn't do very well in first and second year. And then by the end of finals, you are drilled into doing ICE. And that just stands for ideas, concerns, and expectations. And that's basically the key to understanding the patient's perspective. And actually in our own finals, in one of the stations, ICE was actually key to sort of eliciting what the patient was in the consultation room for. And I just asked it at the end with, about a minute remaining. They told me, what they told me. And I was able then to sort of just tailor that last minute to try and sort of clean up anything that I thought that I'd missed missed out on, and actually can sometimes be a way to sort of gauge exactly why the patient's in. And it's something that's really important actually for real life.
Yeah, it's definitely really important for real life, especially in places like GP. It's crucial to try and understand why that patient is actually there and what they're expecting. Just a tip I have that I was taught from a senior doctor: if you get to the end of your history and then you just bluntly ask, what do you think's going on? Sometimes the patients can be thinking, well, have you not listened to what I've said? Or if you ask them, so what are you concerned about? They're going to be thinking, I've just told you all my problems. So a really nice way to sound empathetic here is to say something like, so I've just been listening to everything you've been saying, and I'm going to take it really seriously. But I'd just like to ask you, is there anything that you think might be going on? And that's a really good way just to score some patient marks.
Yeah, absolutely. And I think in GP and other settings where the patients have come in with a patient agenda, in your clinical practice, it's really useful and actually allows patients to come out of a consultation feeling like they've been listened to, feeling like you've actually tried to fix things and not sort of brush things off. So one of the things we wanted to quickly talk about is difficult things that patients may say in a consultation. So this might be something that you pick up by using our ICE structure that we just were discussing. So whenever you're talking about concerns, the patient, in a cancer sort of focused history may say something along the lines of, I'm really worried about this cough or this, sore stomach because actually one of my family friends actually was diagnosed recently with cancer or died of cancer. And that's an insight that is, really, really valuable. And it's something that you actually can't overlook. So I think it's important to have, a nice measured response to that where you take it on board, you don't let it, derail the conversation that you're having, but you move through that and understand what the patient's, worries are, and then you're able to continue asking the questions, because we know in an OSCE setting, it's easy to brush things off, but I think that comes off as very sort of brash and abrasive, and patients definitely don't appreciate that. So for example, the statement, I'm worried about my stomach pains because my dad just died of colon cancer. You could say something along the lines of, look, I'm really sorry to hear that. That must have been very difficult. I can understand why you're worried about this, and this is something that I'm taking really seriously. Obviously we haven't done any tests or anything yet, and I want to finish this history and just ask you a few more questions so that I can figure out what's best to do. But I just want to say that, I'm taking this very seriously, and there are things that we can do, and things that we can test that we can perform.
Absolutely. And although this podcast is all about preparing students for OSCEs, these skills that you develop will transfer throughout your career. And as you go throughout your placements, these things come up all the time. And developing this skill in the first year is really good.
I think one of the next things that, let's say you've done your basic sort of presenting complaint, history presenting complaint, and you're sort of thinking, where will I go now? And just before you go into sort of the past medical history and things like that, I think a quick systems review looks really good. And it might be something that if you're not quite sure what's going on in the OSCE, or even in real life, you're not quite sure why the patient is presented, I think there's a really good sort of head to toe method that you can undertake. So thinking about the head, any recent headaches, fits, faints, funny turns, difficulties with vision.
Moving on down the body, you could come to the lungs, any shortness of breath, any coughs recently, things like that.
Yeah. Thinking, you're in the chest, we're thinking about the heart function, any pains in the chest, any funny, flutters in the chest or palpitations. And then also thinking about just sort of going down a bit further into the tummy, any pains in the tummy, any vomiting, changing the bowel habit, things like that.
Mm-hmm. Urinary problems then, any changes in waterworks. Moving on, skin's important organ, and lots of things commonly present with rashes. Any rashes recently? Other things then, MSK, bony pain, sore joints, things like that.
And I think it's really worthwhile having a list of those whilst you're going through your history, because sometimes you'll pick up things that you weren't even sure that you meant to pick up just by running through a very quick systematic history. And I think just doing it head to toe will make sure you don't miss out anything too big. But in the same vein, don't spend too long on that. That might only be worth a couple of marks, but you might elicit something important, especially in sort of a red flag history where you're not quite sure what's going on. That might be something that's very useful.
Yeah. And it's just a couple of questions on each system. These questions will vary depending on the patient you have in front of you. If it's a 80-year-old patient who's presenting with something, possibly a stroke, some of the questions are going to be slightly different compared to if you've got an 18-year-old sitting in front of you and you're thinking it's gastroenteritis. So you will learn throughout, and as we go through each system, throughout these episodes, we're going to be going through cardiovascular, respiratory, and we'll be going through the questions that you need to ask for each of those. But if you're ever unsure, it's really good just to have some general questions that to ask for each system.
Yeah, I think it's a good structure to fall back on, certainly in an OSCE. Then we're just going to complete down the rest of the history. So we're thinking about things like, the past medical and past surgical history. And again, as Peter said, you don't want to be asking someone who's come on with a possible stroke, when their last sort of appendix that was done in, 30 or 40 years ago. Keep it really clinically relevant. If they're having, chest pains or difficulties with what you worry about to maybe be a heart attack or something with the heart, think about, risk factors, cholesterol, diabetes, high blood pressure. And then in the same vein, if it's a more surgical issue that the patient presented with, any recent operations, just as simple as that will actually cover all that.
And there'll always be 2 or 3 marks here. So you'll get that first mark whenever you say, have you got any relevant past medical history? Then there's always another mark or 2 whenever you ask the specific question that you need to ask. So if this is a person with the chest pain, you'll get the mark for asking them any past medical history, but there will also be a mark there for asking them about things like diabetes, which is really, really significant in someone presenting with chest pain.
Yeah,
on cholesterol, things like that.
Sort of just thinking about, just to complete your history, we'll very quickly run through it. I always think of sort of then there's the family history. And again, you're just focusing on things that are important. If they're coming in with tummy pains, is there a history of cancer? But always being very sensitive when you say that. I don't want to worry you. And these are questions that I have to ask. But has anyone in your family recently or ever been diagnosed with cancer or a type of cancer that you want to specify? Other things that are important, high blood pressure, cholesterol, or conditions that run in families. I think specifically if we're keeping on the chest pain, asking, has their family had, anyone in their family had a recent heart attack, and if they bring that up, specifically at what age. But we can talk more about that when we cover chest pain. There's other basic things then we'd want to cover is, drug history. Do they take any regular medications? Some patients will not know what the medication's name is, but just sort of asking, do you take anything for any conditions that you're currently living with? Do you take any tablets? Is a very easy way to ask it. Then within there, you can ask any allergies, anything over the counter, anything herbal, sort of to cover those. And I'd say you'll get 2 to 3 marks just for covering those sort of smaller sections.
Yeah. Sometimes in real life, depend what your time is like in the OSCE. It's also important sometimes to ask, are they taking their medications? We know that a lot of patients actually don't take their medications as prescribed.
Yeah, absolutely. That's something in GP you'd find quite a lot as you come across patients, is just checking, their compliance and their adherence really to medications. Just thinking about, again, finishing down the rest of the history. So we've gone through most of the structure, but then you've got that last bit, and that's the social history. And actually, I think in first and second year, you don't really realize how important a social structure is in the history. You think, it's just, well, I ask, do you smoke? Do you drink? Things like that. But certainly as you progress through the years, you actually find it's a good way to pick up, especially with older patients or patients with disabilities or physical disabilities. Do you live in, a house by yourself? Do you have a package of care? Do you currently drive? And those are things that are very important in conditions such as, stroke recently, recent seizure, things that would impair, driving or living at home independently. And I think that's something that you don't really realize until slightly later. So it's always really important that you cover that. And again, even just by mentioning it, you're picking up marks in the OSCE and you're showing that you have a really solid structure.
So the last thing we have to talk about is just at the end of the history, you're going to summarize back to the patient. This is often hard to do in an OSCE situation because it is time pressured, but it's actually something that you should definitely do in real life because it allows the patient to know that you've asked everything and you've remembered everything and that they can add in anything that you've forgotten. So it's the last thing that you'll do. Don't worry too much about it if you don't get to that point because it's only a mark. But if you're ever stuck, it can be really helpful to move on to that because it can jog your memory and you can remember some questions that you haven't asked during the history.
Yeah, absolutely. And I think the other crucial thing is to say is that even if you are running out of time, just as you even walk out of the station or as you stand up to say, I would just like to summarize back that history just to the examiner. And you never know, you might pick up a mark that way. To sum it up, the history, especially at sort of a first or second year level, the history is, the majority of the diagnosis, especially in the OSCEs, you probably won't get much clinical information apart from what you elicit in that history. So it's really important to go in with a list of questions in your head, what you think, the differentials might be, and it will pretty much make up the entirety of your diagnosis. And, that's also true for real life. The history is one of the main ways that we can figure out what's going on.
So moving into the next episode, we are going to be moving into a basics of taking a good cardiovascular history. We're just going to do some teaching on that. And then we're going to go through a bit of a mock station just to show you how it should go.
Yep. Thanks, Peter. We'll see you in the next episode. Hopefully you found those those things that we covered today, just in terms of the structure of the history, useful, and we'll pick that back up.
Thanks, Matthew.